right, terrific. Well, I'm very happy to introduce our speaker today, Komal Murali, who is a new postdoctoral fellow in the Comparative and Cost Effectiveness Research Training T32 that Suzanne Bakken leads. And today, Kamal's going to talk about her dissertation research. She recently finished her PhD at the Roy Myers College of Nursing at NYU. And she'll be focusing on a program of research that she's planning to develop related to palliative care and end-of-life strategies for seriously ill adults with multiple chronic conditions, primarily focusing on symptom burden and associated quality of life. So welcome, Komal, to Columbia, to CIPC, and we are excited to hear your presentation.
Thank you, Dr. Hughes, for the introduction, and I'm happy to be here. So the title of my presentation today is Symptom Burden and Quality of Life of Seriously Ill Adults, Exploring Multiple Chronic Conditions and Cancer. Sorry. There we go. So the objectives of this talk will be to provide some background information about multiple chronic conditions, serious illness, and palliative care, and how these concepts have been studied to identify and address a gap in the literature. I will present the research questions and specific aims that were addressed in the study, an adapted conceptual model that I developed to help answer my questions, and discuss the design and methods of the original trial, as well as my dissertation study, as this was a secondary data analysis, the analysis itself, and the findings and discussion. 1/4 of the US population is affected by multiple chronic conditions, or MCC. Those over 65 have a prevalence, for those over 65, the prevalence is 80%, and it is expected to steadily grow by the year 2030 in the presence of rising life expectancy, poor health habits, and clinical complexity. The current accepted definition of MCC by the AHRQ Research Network, which was defined in 2014, defines MCC as an individual having 2 or more chronic conditions that require ongoing medical care and limit the activities of daily living. It is important to note that this definition does not account for complexity, acuity, or severity of serious illness, nor does it account for the cumulative effect of the severity of each of the individual diagnoses, which makes it notoriously difficult to measure in research studies, and it's often left out. MCC can be complicated by serious illness, which is defined by clinical complexity. This is often associated with high symptom burden, increased risk for compromised quality of life, lower functional status, rising healthcare utilization and costs, as well as increased caregiver stress. Serious illness is often fraught with care fragmentation that results from having a multitude of providers for a variety of illnesses and conflicting care plans. And this also leads to adverse outcomes. This population has frequent encounters with healthcare, including greater ED visits, prolonged hospital or ICU stays, as well as increased utilization and costs, typically in the last year of life. Palliative care can be introduced when a seriously ill adult with MCC needs additional care and focus on symptom management and improved quality of life. The National Coalition for Hospice and Palliative Care and the National Consensus Guidelines for Quality Palliative Care in 2018, a comprehensive definition of palliative care is the following and presented in this Venn diagram. Palliative care focuses on expert assessment and management of pain and other symptoms, assessment and support of caregiver needs, and coordination of care. Palliative care also attends to the physical, functional, psychological, practical, and spiritual consequences of a serious illness. It employs a person-centered and family-centered approach to care, and through early integration into the care plan, palliative care can improve quality of life for patients and their families. In my study, I sought to address a problem and gap. The seriously ill adults with MCC, with and without cancer, receiving palliative care at the end of life are not well described, and the evidence related to MCC and the approaches to care do not necessarily account for the complexity, acuity, or severity of the seriously ill adult. And a conceptual model was lacking, one that incorporates palliative care in addressing serious illness and MCC research. So I was able to develop one to conceptually guide my study. When developing the specific aims, I had three main research questions in mind. What is the symptom burden and quality of life profile of seriously ill adults with MCC, with and without cancer, in a palliative care cohort at the end of life? Can we identify latent subgroups comprised of seriously ill adults based on symptom burden, comorbidity burden, and/or mortality risk? And what are the demographic and clinical predictors of latent subgroup membership, for example, quality of life and functional status? This study was a secondary analysis of clinical trial data. Aim 1 was to describe the sociodemographic and clinical characteristics of seriously ill adults with MCC, with and without cancer, receiving palliative care. Aim 2 was to identify latent subgroups of seriously ill adults based on symptom burden and comorbidity burden and mortality risk. And an exploratory Aim 3 sought to examine the covariates or predictors of membership in each of those latent subgroups, including quality of life and functional status. To conceptually inform this study, we created a conceptual model that integrates palliative care and how we think about serious illness and MCC research. And ultimately, conceptual models such as this are meant to address the gaps in the literature that can potentially inform care strategies to improve outcomes in a complex patient population, such as those with serious illness and MCC. This model was adapted based on a model created by the AHRQ Multiple Chronic Conditions Research Network in 2014. The original model sought to address the gap between the needs and services patients receive by including complexity as the mitigating factor among those who have MCC. In the adapted model, as you can see, the seriously ill adult with MCC is placed central in the model, with the gap between needs and services being represented by a bidirectional arrow. The contextual factors that influence the individual characteristics, along with social support, population health, inequalities or inequities on the left, influence the needs of the individual. On the right side of the model, the health system, the research base, evidence base, dissemination efforts, and health policy are impacted by contextual factors. These factors influence community resources and the health system to determine the services that are received by the individual. Palliative care, when received by the individual, influence the number of visits, the service mix, the information received, and the quality of care, as well as the experience of the individual and their family. Ultimately, this impacts patient outcomes. And as you can see, all of the person-specific and contextual-specific factors, including population health and inequalities, as well as the overall evidence base and health policy, come together to contribute to overall patient outcomes. This is a detailed version of the adapted conceptual model that highlights the important components associated with each major concept. Many of these concepts are highlighted within the red box, and they're explored in this study. As this was a secondary data analysis, data from the multi-site randomized trial of continuing versus discontinuing statins by Kuttner and colleagues was used to conduct the analysis. The primary outcomes of the original study were published in 2015. This study employed a multi-center parallel group, unblinded, pragmatic clinical trial design. The primary objective of the original study was to evaluate the safety, clinical outcomes, and cost of discontinuing statin medications for those with advanced life-limiting illness receiving palliative care at the end of life. The original study inclusion criteria are listed here. Individuals were included if they had a serious illness as determined by a provider with a life expectancy of 1 month to 1 year, or statin therapy for 3 months or more for preventative purposes only, a recent deterioration in functional status, and no recent active cardiovascular disease or cardiovascular accident. The secondary data analysis which was conducted included all participants in the sample who met the definition of serious illness. The cross-sectional data included validated measurement tools for symptom burden, quality of life, MCC, and functional status, which provided reliable data for a secondary analysis and also provided the relevant data I needed to answer the research questions and the specific aims we developed. This study underwent expedited IRB approval at NYU. Listed here are the sociodemographic covariates described in the study. These include age, sex, race, ethnicity, education, and insurance status. We examined older age by creating a 3-category variable, including those under the age of 65, individuals aged 65 to 74, and those 75 or older. Listed here are the clinical covariates incorporated in the analysis, including the number of medications, polypharmacy, hospice enrollment at baseline, functional status as measured by the Australia Modified Karnofsky Performance Scale, MCC as measured by the Charlson Comorbidity Index, symptom burden as measured by the Edmonton Symptom Assessment System, and quality of life as measured by the McGill Quality of Life Questionnaire. We accounted for the presence of MCC within the sample by creating a new variable, as this was not originally a part of the data set, that represented those with 2 or more chronic conditions for which they were receiving care and had functional status limitations. It's important to note that because this was a seriously ill population at the end of life, every single participant had functional status limitations, and they were receiving regular medical care for a variety of conditions that they were admitted for. So symptom burden was measured by the Edmonton Symptom Assessment System. Each symptom item is a self-reported item on a scale of 0 to 10, with a self-reported score of 10 representing the highest severity for that symptom. Clinical cut points delineating the severity of symptoms are described in the literature and were operationalized to complete the analyses. The McGill Quality of Life Questionnaire was used to measure quality of life, and the overall quality of life score represents the overall MQOLQ score. The questionnaire itself has 4 subscales, including physical symptoms, psychological symptoms, well-being, and support. And the total MQOLQ is calculated as a mean of the values for each subscale. This score was categorized using quartile categories for analytic purposes. And for example, higher MQOLQ scores indicated higher quality of life. The analyses for each AIM are listed here. AIM 1 was achieved by using descriptive statistics, Pearson's chi-square or Fisher's exact test, Wilcoxon rank sum test, and logistic regression to compare seriously ill adults with MCC with and without cancer. AIM 2 was achieved by conducting 2 separate latent class analyses. Latent class analysis is a statistical method for identifying class membership among participants in a sample using categorical and/or continuous observed variables that are latent predictor variables. This study conducted 2 analyses. One was based on symptom burden and the other based on comorbidity burden and mortality risk. After identifying latent subgroups, Pearson's chi-square or Fisher's exact test, where appropriate, were used to examine bivariate associations between the demographic and clinical covariates as well as the latent subgroups. AIM 3 was achieved by conducting multinomial logistic regression. This was to determine predictors of symptom burden latent subgroup membership. Multinomial logistic regression allows for conducting logistic regression using a multi-category outcome variable. The symptom burden latent subgroups made up the outcome variable, and the covariates that were predictive of subgroup membership were also incorporated into the model, based on theoretical understanding, but also based on bivariate analyses. It is important to note that in this study, AIM 1 was predicated on the completion of the symptom burden L.CA. These are the baseline characteristics of the sample. 287 seriously ill adults with available symptom burden data were included in the analysis. 75% were 65 or older, and 74% met criteria for multiple chronic conditions. And there were more men than women in the sample. There were 80% non-Hispanic white participants and 15.3% non-Hispanic Black participants. 54% completed high school, and the majority of participants received Medicare or Medicaid as their primary form of insurance. 30% were enrolled in hospice at baseline, and 41% of participants had a lower functional status as measured by the AKPS. And I must note here that on average, the majority of the participants had an AKPS score of 70 or lower, which is relatively functionally impaired. But the individuals who were in this 41% group of individuals who had lower functional status had 50 or lower, which is significantly functionally impaired. And the average MQOLQ score was 6.15. In the comparison between seriously ill adults with MCC with and without cancer, Among those with MCC, 25.4% had MCC without cancer, and 48.8% had MCC with cancer. And among those without cancer, there is a statistically significant lower functional status, higher total number of medications, and greater hospice enrollment at baseline compared to those with cancer. Individuals with MCC and cancer had higher functional status scores, higher prevalence of nausea, drowsiness, and poor appetite. In the final logistic regression model seen here, comparing MCC with and without cancer, individuals with lower functional status were significantly more likely to have MCC without cancer. This relationship shows the lower functional status was associated with a 2.56 greater odds of having MCC without cancer in the adjusted model. In addition, hospice enrollment at baseline was associated with a 3.7 times greater likelihood of having MCC without cancer. The symptom burden L.CA was conducted using the following predictor variables. Each of the 9 self-reported ESAS items, symptom items, categorized based on severity using clinical cut points described by Hui and Barrera in 2016, as well as quartile categories of the total ESAS score in a reverse Poisson distribution. The total ESAS score is a sum of the score of the 9 symptom items. In a seriously ill population, it's important to note that there were higher total ESAS scores given considerable symptom burden in the sample. Reversing the quartile categories using a Poisson distribution was actually more clinically representative of the symptom burden within the sample. Therefore, on average, the reference category of 0 included individuals with total ESAS scores of 38 or greater, indicating high symptom burden. Maximum likelihood estimation procedures and model fit statistics were used to identify optimal representation of latent subgroups based on observed data, including the smallest Bayesian information criterion, a significant parametric bootstrapped likelihood ratio test, p-value, and an entropy greater than 0.8. The symptom burden L.CA model had well-powered fit statistics, and the percentage of individuals in each class reporting non-mild, moderate, or severe symptom scores for each ESAS item was compared to that of the overall sample. A difference of 5% or greater indicated posterior probability that there was membership in this specific latent subgroup based on symptom burden. So these were the findings of this latent class analysis. The symptom burden L.CA identified a 3 subgroup model. 3 subgroups were identified, including those with low symptom burden, moderate symptom burden, and high symptom burden. 99 participants had low symptom burden subgroup membership with none or mild symptoms. 127 participants had moderate symptom burden subgroup membership with mild or moderate symptoms, and the most prevalent among them included pain, fatigue, anxiousness, average or poor appetite, average or poor well-being, and shortness of breath. 61 participants had high symptom burden subgroup membership with moderate or severe symptoms, including pain, fatigue, nausea, depressive symptoms, anxiousness, drowsiness, worst appetite, worst well-being, shortness of breath. And nausea was specific only to this group. In the multinomial logistic regression model that examined predictors of symptom burden latent subgroup membership, this study found that individuals with lower overall quality of life and a score of 6 or lower had significantly greater likelihood of having high symptom burden latent subgroup membership. Specifically, individuals with an overall quality of life score of 0 to 5 had a 13.5 times greater likelihood of high symptom burden latent subgroup membership. Among those with MCC in this sample, they had a statistically significant 3.26 greater odds of having high symptom burden latent subgroup membership compared to those without MCC. The second L.CA conducted was using the Charlson Comorbidity Index. This was done to identify subgroups based on comorbidity burden and mortality risk. In this analysis, all 381 participants with baseline CCI data were included in the analysis. The predictor variables for the L.CA included presence of each disease diagnosis and diagnoses not accounted for by the CCI. The total CCI score categories were also categorized using clinically relevant cut points. For reference, a CCI score of 5 or greater is associated with a 85% one-year mortality risk. Maximum likelihood estimation procedures and model fit statistics were used to identify optimal representation of latent subgroups based on the observed data, including the smallest Bayesian information criterion, a significant parametric bootstrap likelihood ratio test p-value, and an entropy greater than 0.8. The L.CA had well-powered fit statistics, and the percentage of individuals with presence of specific diagnoses and mortality risk were compared to that of the overall sample. A difference of 5% or greater indicated posterior probability of membership in a latent subgroup based on comorbidity burden and mortality risk. The CCI L.CA revealed a 3-subgroup model. This included 178 participants in the low to moderate CCI, which indicates a CCI of 1 to 5, including those with MCC. And the most highly prevalent condition in this group was COPD, with 45% prevalence, along with CVD, CHF, MI, dementia, diabetes, and lymphoma. 2 subgroups had high CCI scores, or CCIs greater than 5. There were 64 participants in the group with high CCI and multiple chronic conditions, and the conditions in this subgroup were more advanced in nature, including AIDS, peripheral vascular disease, hemiplegia, ulcers, diabetes with end organ damage, liver disease, renal disease, leukemia, and non-metastatic cancers. There were 139 participants with high CCI and metastatic cancer. All participants with metastatic cancer were members of this subgroup, as well as severe liver disease and connective tissue disease. In summary, the key findings of this dissertation study were that MCC is associated with high symptom burden, latent subgroup membership. MCC without cancer is associated with lower functional status, hospice use, and greater number of medications at baseline. Lower overall quality of life is associated with high symptom burden, latent subgroup membership. Older adults are less likely to have moderate or high symptom burden, latent subgroup membership. This study provided a comprehensive description of seriously ill adults with MCC using a variety of data that capture the clinical profile of this complex population. The findings of the study have made clear that symptom burden and quality of life are in fact linked in seriously ill adults, which is consistent with the existing literature and prior analyses done in these types of populations. Older adults are less likely to have moderate or high symptom burden latent subgroup membership in our analysis, which was a surprising finding, which is consistent actually with some literature that shows that older adults may be less likely to perceive their symptoms as burdensome and may in turn impact how they self-report symptoms at the end of life. We also note that seriously ill adults with MCC who do not have cancer may perhaps have a greater burden of symptoms and impairment in their functional status compared to seriously ill adults with MCC and cancer. This may be due to the clustering of symptoms associated with non-cancer MCCs. For example, there was a high prevalence of shortness of breath among those with cardiopulmonary conditions and among those with multiple chronic conditions. Hospice use is more prevalent among non-cancer patients with MCC, hospice use is more prevalent among non-cancer patients with MCC and serious illness compared to those with cancer, especially in the last year of life. And while this requires further study, it may be likely that those with MCC and cancer are referred to hospice later in their disease trajectories or in their treatment plans compared to those without cancer. The link between MCC and high symptom burden is critical to note. And this finding supports the notion that research focusing on those with MCC and serious illness must focus on symptom burden and quality of life to improve outcomes related to this complex population. And finally, the exploration of comorbidity burden and mortality risk and the associated mortality risk allows for the identification of disease clusters. This has the potential to be clinically useful in practice, especially at the end of life, when seeking to address the symptom burden needs of those with MCC and to identify whether certain disease clusters are associated with a certain cluster of symptoms. The strengths of this study are listed here. Given limited data sets in palliative care, or data sets that include comprehensive information about palliative care and the type of care that is delivered, This study was based on data from a multi-site trial, including all participants receiving palliative care. It is important to note that the primary study had strong methodological rigor and provided useful data, validated measurement tools for further analyses beyond the original aim beyond the primary aim of the study. The study used rigorously tested measurement tools for MCC, symptom burden, quality of life, and functional status, and therefore the findings have potential to inform prospective studies. We also can find significant evidence from the findings to aid in developing palliative care interventions focused on improving symptom burden and quality of life, especially for those who have serious illness and multiple chronic conditions at the end of life, because we know that the clinical complexity is often greater and the symptom burden tends to be increased when you have a competing multiple chronic conditions that can be complicated in how they present clinically. This dissertation study provides foundational evidence for future studies that seek to better understand this population. And ultimately, the goal would be to develop effective goal concordant care that with high quality interdisciplinary solutions to address the issues such as poor quality of life, lower functional status, and increased symptom burden to try to improve outcomes for this population. It is important to discuss the limitations. The limitations of the original study are applicable as this is a secondary data analysis, and the study included a lot of important variable measurement tools for the variables that I was interested in. However, all the relevant information related to palliative care, such as the description of the palliative care team, the type of palliative care that was delivered, the team members that were involved, and the measure of the palliative performance scale, among many other issues related to how we measure palliative care, were not available. Also, we did not know the type, extent, or duration of palliative care, nor did we know the number of visits received by the participant by a palliative care provider. There was a fair amount of missing data resulting in significant loss of sample size given the seriously ill nature of the sample. Many participants died during the study, and many were unable to self-report symptoms based on their severity of illness. However, the robust statistics for the L.CA modeling in particular provided reliable data to really understand and better examine predictors of latent subgroup membership. And due to the original study aims, the individuals with recent active cardiovascular accident or cardiovascular disease were not included, which left out a major comorbidity. And finally, the cross-sectional nature of the study limits our understanding of how quality of life, functional status, and symptom burden are affected over time, especially in those receiving palliative care in the last year of life. There are several education, practice, and policy implications to consider. I will discuss the three main in this presentation. The first is that the education and training of healthcare professionals with a focus on serious illness and MCC is greatly needed. There still is a tendency to focus on the one disease approach to care, and palliative care can help to mitigate some of this and try to improve outcomes by focusing on a whole person or a whole body perspective and trying to incorporate consideration for the cumulative effect of having multiple chronic conditions, and also paying greater attention to the clinical complexity that arises from having MCC. There is also a need for increasing specialty trained palliative care workforce to improve patient outcomes, especially in the setting of an aging, seriously ill populace. And finally, any efforts to mitigate the rising costs in healthcare utilization must take into account that seriously ill adults with MCC are complex and they require very specific goal concordant care to address some of these issues at the end of life. Future studies should include prospective trials with seriously ill older adults with MCC, as they've been historically excluded from a lot of palliative care trials. However, in recent studies and the trends in palliative care research, individuals with MCC and serious illness are starting to be incorporated back into studies because we need to have a better way of trying to address these outcomes at the end of life. And typically, many studies have focused on those with cancer alone. And as we know, older adults can have multiple chronic conditions in addition to cancer. So trying to better understand how we can serve this population in a more effective and goal concordant way should be incorporated into future studies. This includes interventions that can address lower functional status, interventions that can address poor quality of life, and ultimately making sure that we are focusing on the high symptom burden in this population at the end of life is important. And outcome studies must adequately address and measure MCC, symptom burden, quality of life, and functional status, so that they're incorporating the complexity associated with having serious illness and MCC at the same time. New measurement tools specific to serious illness and MCC are necessary, as I just said, and the exploration of disparate hospice use between MCC with and without cancer also warrants further study. Palliative care interventions for non-cancer serious illness are highly lacking, and in further studying, further study should also include those with Alzheimer's disease and Alzheimer's disease-related dementias. And I mention this because it's often difficult to include individuals with serious illness and Alzheimer's or dementia, because the issue of cognitive impairment can make measurement really difficult, especially if you don't have consistency in measurement across studies, and the availability of the caregiver must be considered as well. And more frequent palliative care integration into the care of seriously ill adults with MCC during critical illness is necessary. And future research should also address the significant palliative care disparities related to race and ethnicity, culture, and access across the board. So to end my presentation, I just wanted to present that I'll be able to hopefully publish 4 papers from my dissertation. The conceptual model that was developed has already been published in the American Journal of Hospice and Palliative Medicine, and the 3 remaining database papers are in the process of or pending submission. I just wanted to take a moment to acknowledge the funding that I received as a PhD student and now as a postdoc. I received funding from the NYU Clinical and Translational Science Institute, the Jonas Center for Nursing Excellence, and the Norman S. Vogt Doctoral Scholarship. I also wanted to acknowledge the Palliative Care Research Cooperative for being so supportive and willing to allow me to use data from their clinical trial to address the research questions that I had. And I'm now grateful to be receiving postdoc funding at Columbia Nursing through the CERTUB Postdoctoral Research Fellowship. And people often say to me that it takes a village to raise children, but I think it takes a village to raise a researcher and a PhD student. So I would not be here. I apologize, this isn't advancing. There we go. I would not be here without the individuals who are listed here, and I'm really grateful to have had a wonderful mentorship team at NYU led by Dr. Brody, who was my PhD advisor and mentor, and has been a supporter from day one. And now to be under the mentorship of Dr. Stone. I'm grateful to be here, and I'm looking forward to working on my research going forward. And also I wanted to thank the Dr. Stone and the CIPC for allowing me this opportunity to present my findings here today. So thank you for listening, and I'm happy to take any questions and comments at this time.
Thank you. People can clap.
Oh, thanks.
So we're going to take the question. This absolutely was, I enjoyed the presentation very much.
Thank you.
And it was really great. We're going to take questions in the chat box. And so people, please write your questions, because if everybody gets off, we'll have a lot of feedback. But write your questions in the chat box. And I'm going to start. I have a couple of questions, Komal. One is, it was interesting that you found, one's more a comment, that you found that the cancer patients were less likely to be in hospice, because some of you might remember when Betty Farrell came and gave us a presentation. That was something that she said, you know, very much, that cancer patients do not want to go into hospice because to them that means they're giving up and they're still wanting their, to be on a trial and in their medicine. So I wasn't surprised about that. But I do have one question about, thinking about Leah and stuff about health disparities. In your models, was there any difference by racial or ethnic minorities, or no?
There wasn't. And I think one of the reasons why I didn't find any differences is because of the sample size and the lack of diversity within the sample to begin with. Like I said, so 80% of the participants were non-Hispanic white, and I didn't put it in the description of the characteristics, but so 15% were non-Hispanic Black, and in less than 4% were Hispanic. So, and I think there were less than 1% other. So I think just because of the lack of diversity, but also the sample size, I wasn't able to find any differences.
Great. Marlene has a question, Marlene McHugh. For patients who have multiple chronic conditions and are fail and unable to self-report the ESAS, did you use another tool? Was there other data available?
There was not other data available. So this data was from the clinical trial, and if they were unable to self-report, a caregiver was often asked or involved, but because it is a self-reported tool, I think just to maintain fidelity to the tool itself, if they weren't able to answer, they didn't incorporate that data point into the data set.
Okay, great. And Dr. Shang has a question. She says, "This is a wonderful presentation, Komal. Could you talk about how to obtain the data from the Palliative Care Research Cooperative?" This
Absolutely.
Absolutely. Other people.
Yeah. So Palliative Care Research Cooperative is a wonderful resource for those interested in palliative and end-of-life care research. They have a data repository on their website, and you can go through the process of submitting a research proposal to their scientific review committee. And really what's involved is becoming a member. And from what I recall, it wasn't really too difficult to become a member. I expressed interest in palliative care research, and of course it helps to have a member also vouching for you. But once you become a member, you can submit a research proposal and access some of their data sets. They actually have every single data set listed on their website and what's available. You don't really know the specifics of the data until your proposal is approved, and then they send you a code book and the details of the data set. But yeah, it's a really great, it was a great opportunity for me, especially at the time in 2016, 2017, when I was developing my study. I was looking at every possible resource to find palliative care data, which was really tough, and I think it still is tough. But Dr. Brody mentioned this to me, and he's like, you should look into Palliative Care Research Cooperative, become a member, see if anybody has data that can help you answer this question or these questions that you have. And it just so worked out that this trial incorporated all of these wonderfully validated measurement tools to answer these questions.
Yeah, no, it's great. Dr. Corwin has another question. She says, "Great job, Komal. One question, on your theoretical framework diagram, I believe you included the sole need social support. Could you discuss this?"
Yes, so I'm actually going to go back to it if that's okay.
Sure.
Okay, so social support here. So I'm sorry, do you mind repeating the question again?
Yeah. Betsy, you ask it. It's okay.
I was just wondering about the needs in that diagram. And I can see now that I'm looking at it again, it's that social support addresses the needs, but what sort of needs are you thinking about there?
So when I think about the social support and the needs, or the needs that are determined by social support, I'm talking mainly about individuals who are very much tied to a caregiver in their care, and often this includes participants who have cognitive impairment or severe functional status impairment. And so we talk about, in palliative and end-of-life care, we often talk about caregivers as being a part of the care plan or the treatment plan. And if you don't have a caregiver or a support system, whether it's at home or in your family or in your community, your needs will really be high. And so ultimately the healthcare system or the healthcare provider or anybody you're engaging with in the healthcare system will have to sort of compensate for the lack of a support system. And so that's why social support is a huge part of this, because if you don't have social support, your needs are going to be much greater than those who do.
Okay, great, thanks. I have another question for you. As a nurse that's practiced in an ICU, or for our palliative care clinicians that are have watched your presentation. What do you think, how can they use this research? How can you use this research in your practice?
So I would say that the main goal for me for this conceptual model was try to incorporate palliative care in how we think about research for serious illness and MCC. And when I was working with my committee and especially Dr. Kelly, who's a palliative care researcher at Mount Sinai, a lot of her work focuses on serious illness. And when we talked about how this could potentially impact palliative care, we talked about how we can help people frame their research questions to address the gaps in the literature. So that's kind of how I felt this could potentially impact palliative care, on a broad level. But for me personally as a nurse and as someone who's interested in this population, I found it interesting that those with multiple chronic conditions were more functionally impaired, had poor quality of life, and that population still remains very, very interesting to me. And what I hope to do with the findings, and I'm not exactly sure yet, but I am hoping to take some of these findings and try to apply it to how we take care of people with high symptom burden who are critically ill or post-critical illness, because many older adults who are critically ill have a lot of these same characteristics when they come into the hospital or when they're hospitalized in the ICU. And just through conversations with Dr. Hua, who's also who's my interdisciplinary mentor, I'm starting to think about what I'm most interested in, and I'm really interested in symptom burden. So I'm hoping to take some of these predictive factors that address that kind of determine subgroup membership to try to see if I can incorporate these findings into a critical care or critically ill population. Still figuring out what that means. And right now I'm sort of in the discussions of how are we measuring symptom burden in critically ill older adults? What does that mean? Do we measure that? Or because they're so acutely ill, many of these people are intubated or they're sedated. What does any of that mean in the ICU setting? And just from my conversations with Dr. Hua, it doesn't look like we're measuring this. It doesn't look like there is a way to measure this. So that's kind of something I've been thinking more and more about. But yes, so the findings I think I'm most interested in are the symptom burden findings and how this impacts the seriously ill older adult population.
It's interesting that the elderly can sort of handle their symptoms more.
Right, that was a really interesting finding. And I spoke with Dr. Brody with this for a long time. We were talking about the findings, and he's like, he's like, it's interesting, but I'm not too surprised because we do know that there are generational differences in how people experience and report pain. And this, this isn't like, every older adult person will say, I don't really have pain or I don't have symptoms. That's not to say that, but they just tend to report less symptoms and less burdensome symptoms, especially at the end of life. And I found that interesting. And I wonder if it's because they're looking at it from a big picture perspective, like, I have all these conditions and it's like the end of the road for me. If I have a little pain, it's okay. We talked about this for a long time, but yes, I did find that interesting. And I don't know if it's because we're not measuring it well or addressing it well enough or asking the right questions. These are all things that come to mind.
Yeah. Natasha has a question, but Betsy has one before that. Betsy, do you want to just ask your question?
Yeah, because it follows up on this. I've been thinking about the age finding that you described. And within that population of severe symptoms with including cancer, having cancer, I saw some suggestion, but I wondered if you looked directly, that those are a younger population than your severe symptoms without cancer. So some younger people there. I wondered if you looked within that the group of the group with cancer, multiple chronic conditions with cancer, to compare the younger to the older within that group. I know you compared them across groups, but I'm thinking that the younger people might have fewer symptoms within the cancer population because they're younger. They just don't have arthritis or, as COPD, something like that. Did you look within that group to look for the differences between that age might have had?
I didn't do a specific analysis looking within that group, but I did notice in terms of just prevalence of symptoms that among the younger, and I say younger, I mean people under 65 within the sample, like they had a greater prevalence of pain and nausea and appetite. And a lot of these people had metastatic cancer and were on, since they were not on, many of them were not on hospice yet, they were still receiving active treatment. So I think some of that was really treatment related, but yes, it would be interesting to look more closely at that to see the differences.
You did collect data on sex. Did you report on sex as a biological variable? Did you see, I'm sorry, you might have said that, but I missed
yes, and there was no difference.
Natasha asked, how many of the symptoms are related to long-term prescription drug usage?
So that wasn't available in the data. What was available was the number of medications at baseline, and this was a clinical trial, so they had longitudinal data. But for me to be able to conduct a latent class analysis on the sample, I had to do a cross-sectional baseline analysis. But I don't know how many of these. I don't know how much of it was related to that, but. The number of medications was pretty significant, and polypharmacy was very substantial in the sample, and I wrote about that in depth in my dissertation. But so many of these participants had 15 or more medications at baseline.
Wow.
Yeah. So and the original aim of the trial was to look at discontinuing statins. So polypharmacy was a huge part of the original trial. So I looked at it in this, and ultimately what it comes down to is that it just when it didn't make any difference in my final models, it did complicate the clinical picture for these individuals. And so yeah, that would be interesting, but unfortunately I couldn't answer that question.
Yeah.
Sorry, Pat, we have about 5 minutes left, a little over 5 minutes.
Thanks. We got one more question then from Carol DeBello. And she's wondering if there may have been a higher rate of cognitive impairment among the older patients. That equals fewer ESOS scores for that population. If caregivers reported the ESOS, it may not have been as accurate.
Right. Yeah. So there was a fair amount. There was 30% of the sample had cognitive impairment. And they did say that in the original trial, if the individual themselves was unable to answer the symptom questionnaire, that their caregiver would help. But I don't know that it was always available to them, or if they were always able to collect that data.
Okay. Well, again, big round of applause for Komal. Welcome to Columbia. We're glad you're here.
Thank you for having me, and thank you for the opportunity to present today.
Yeah, no, it's great. And you're starting off a great lineup. Ashley, if you can put on the slide of our next, we have our next 2 meetings. We have people from outside. Let's see, something just happened with my screen. And I can't hear you, Ashley. You're on mute.
1 second.
Okay. So we have the flyer for the next 2 times, and there's a link if you want to, sign up. We have Holly Prigerson and Catherine Ornstein are going to come and present. I think that's our next one. And then after that, it's Jean Kuttner, whose data set you use, will be presenting. So the next one is Thursday, October 29th. And I can't read that, mental health at the end of life into bereavement and caregiving at the end of life, reframing healthcare delivery beyond the individual and the hospital setting. So this should be terrific. We have 2 people, so we got it a little bit longer time to 1:30. Should be terrific presentations, and it's also very nice for CIPC to be bringing in people for local other palliative care researchers locally that from other centers, and these are 2 of the main centers in New York, so that's good. And then the next one after that will be Jean Kuttner. And so, and she heads up the PCRC. So I think we're going to have a terrific lineup this fall. And
we hope to have your mentor, Ab Brody, sometime next year.
Yeah.
Yep.
Yeah, he's going to come in February or something. I think February.
Yes, February.
Okay, so, and I think Ashley was going to put in the link if you want to sign up in the chat box. You can do that if you have it. And thank you, everybody. Really appreciate it. And you probably will be getting an email about for our evaluation.
Yes, please fill it out because it helps us know how to, what topics you're most interested in, which ones are most helpful, and it'll improve our programming going forward. So please do that. Thank you, everyone.
Thanks, Komal. Well done.
Thank you. Bye.
Bye-bye.